Hey everyone, and welcome to your renal rotation here at KTPH. We've put together this quick guide to get you ready for the wards, focusing on two of the most important patient journeys you're going to see, the transplant recipient and the patient on a conservative kidney management pathway. Let's get right into it.
Okay, so let's dive in. The best way to get a feel for this rotation is to understand two core types of patients you'll be managing every single day. Honestly, if you can get your head around these two different mindsets, you're going to have a great rotation.
And really, it all boils down to this. For your transplant patient, your mission is crystal clear. Protect that donated kidney, the allograft, at all costs. But for your CKM patient, the whole game changes. The goal shifts completely to preserving their quality of life. We're talking comfort, dignity, and symptom control. If you get this fundamental difference, everything else will start to make sense.
All right, case number one. Let's start with a scenario that I promise you will encounter, probably in your first week. This is where you get to put on your detective hat.
Okay, picture this. It's 3 in the morning, your pager goes off, and this is the story. Mr. Tan is in the ED, and his numbers are off. Before you even walk into that room, your brain should already be firing, piecing together a plan. So, what's running through your head? What are the absolute non-negotiables you need to find out right away? The history you take in these first few minutes is so critical, and it's totally different from a standard medical workup. You have to be a bit obsessive here. First, why did he have end-stage renal disease in the first place? Was it a living or deceased donor transplant? What's his cocktail of immunosuppressants? And have there been any recent changes? And this one is huge. You have to know his baseline creatinine. Without that number, you're basically flying blind. This is what builds your differential. Now, listen up, because if you remember one thing about these patients, it's this. In a normal patient, a tiny bump in serum creatinine might not raise alarms. But in a transplant recipient, that small change could be the tip of a massive iceberg. It could be nothing, or it could be acute rejection. You absolutely cannot afford to ignore it. So here's your game plan. Always start simple. You know, Occam's razor. Is he just dehydrated? Could it be a simple UTI? Next, become a pharmacist. Scour that drug chart. Are there any kidney toxic drugs? Anything that could be messing with his calcineurin inhibitors, like tacrolimus? Then and only then do you start hunting for the zebras, the specific infections like CMV or BK virus, and of course, acute rejection. Your investigation should follow that same logic. Look, you're never on an island here. Every single transplant patient who comes in gets discussed with the on-duty nephrologist. But your role is so important. You're on the front line. Your job is to do that solid initial workup and present a clear, organized picture so that we can make the right decisions fast. Okay, let's completely switch gears now. We're going from detective work to something completely different. For this next case, the biggest challenge isn't diagnostic at all. It's about communication, and it's deeply, deeply human. So you're called for a family conference. Your patient is M. Lee. She's 88, very frail, has a lot going on. Heart failure, advanced kidney disease, maybe some dementia. And her family, who love her dearly, look at you and they ask that huge, heavy question. Doctor, should she start dialysis?
And I really want to stress this. CKM, or conservative kidney management, is not about giving up. It is not doing nothing. It's an active, compassionate medical plan. It involves the whole team, doctors, nurses, palliative care, all working together to manage symptoms and make sure the patient's remaining time is as comfortable and dignified as possible.
So how on earth do you navigate that conversation? This is where your most powerful tool isn't a stethoscope or a lab form. It's your ability to communicate with empathy and clarity. And the good news is, you don't have to just wing it. There are frameworks to guide you.
Think of Johnson's 4 boxes as your roadmap for these tough talks. It makes sure you cover all the bases. What are the cold, hard medical facts? What does the patient actually want? What are their values? What would their life really look like with or without dialysis? And are there other things to consider, like family support? It helps make sure the decision is thoughtful and complete.
And after all the complex medical discussions, it often comes down to this one incredibly simple, powerful question. Asking the patient or the family, what is most important for you right now? It's the key that unlocks shared decision-making. It changes the focus from what we can do to what we should do for this specific person.
So, you see, two totally different patients, two totally different goals. And that means you, as the medical officer, have to be able to wear two very different hats.
This slide just nails it. For the transplant patient, you're a detective. You're aggressive, you're focused on the organ, you're preserving it. But for the CKD patient, you're a guide. You're communicating, you're focused on the person, and your goal is their comfort. It's a fundamental shift in your approach.
All right, let's wrap this up. If there's one single thing you should take with you as you walk onto the wards for your first day, what should it be?
It's this. Every time you see a new patient, before you do anything else, just pause and ask yourself, what is the goal of care here? Are we trying to preserve an organ, or are we trying to preserve a person's quality of life? Answering that one question first will shape every decision you make, every conversation you have, and every action you take. Get that right, and you're going to do great. Welcome to the team. We're really glad to have you.